Hello and welcome to part 3 of clinical cases for the cardiovascular block. Today we're going to take a look at some of the valvular abnormalities that occur within the heart across the 4 valves, the aortic, the pulmonary, the tricuspid and the mitral. Essentially there are 2 key concepts you need to be aware of this video, and that's stenosis and regurgitation, and also be aware that these can occur together. Essentially stenosis is a narrowing of a valve. Essentially it's harder for blood to pass through that valve. Regurgitation is a backflow of blood through a valve, and keeping in mind those 2 key concepts for us going through these valvular abnormalities will help no end. In terms first of all of mitral stenosis, so we're looking at the mitral valve, which we know is on the left hand side of the heart between the left atrium and left ventricle. This is made up of 2 cusps, an anterior and a posterior leaflet. Essentially during ventricular systole, so when the ventricles are contracting, this valve therefore must close to prevent the backflow of blood into the left atrium. During ventricular diastole, so when it's relaxing and filling, it therefore opens to allow blood to flow passively or actively from the atria to the ventricles. Therefore, in mitral stenosis, this is an obstruction of the inflow of blood into the left ventricle during diastole. The 2 main causes of mitral stenosis include rheumatic fever and calcium deposits with age. Rheumatic fever is particularly the most important to be aware of, as it can cause valvular abnormalities in 2 ways. In the case of mitral stenosis, it doesn't cause fibrosis, but it can cause the leaflets to fuse together, and this is referred to as commissural fusion. This narrows the opening of the mitral valve from 4.6 cm squared normally when it's open to around 2 cm squared in a mitral stenosis, and as a result it's a lot harder for that blood to get through to the ventricles. On another case, rheumatic fever can cause valvular abnormalities via fibrosis, and we'll explore that a little bit more later on. One of the most important consequences to be aware of is that actually mitral stenosis can cause right-sided heart failure, so a valve that's on the left can cause right-sided heart failure. So the reason behind this is when we narrow the mitral valve, essentially this causes an increased volume in the left atrium of blood, and therefore if you've got an increased volume of blood you're going to get an increased pressure in the left atrium as well. Now with this constant increased pressure within the left atrium, this can cause blood to backflow up into the pulmonary circulation. Now if you think about your normal left atrium, it's receiving blood from the pulmonary veins from the lungs, and therefore blood can backflow up into the pulmonary circulation and consequently cause pulmonary edema. In the presence of pulmonary edema, you're actually also likely to get pulmonary hypertension due to an increased pressure in the lungs, and therefore this makes it harder for the right ventricle to pump, because obviously normally the right ventricle pumps out through the pulmonary trunk, the pulmonary arteries to the lung. And therefore the right ventricle will hypertrophy as well. So therefore the right ventricle will have additional sarcomeres within its wall to bulk up and try to compensate to pump blood to the lungs. As a result, mitral stenosis can therefore lead to right-sided heart failure when the heart can no longer pump effectively to the lungs. In terms of symptoms of mitral stenosis, you may see fatigue, peripheral edema, palpitations, dizziness, as well as chest discomfort or pain. And obviously if pulmonary edema has ensued, you will expect to see shortness of breath and difficulty breathing as well. Mitral stenosis is a mechanical fault, and therefore it's important to be aware if we were going to treat this with medication, obviously it may help the condition, but it may not, it doesn't treat it essentially, it may just prevent disease progression in a more rapid fashion. So we can give beta blockers and calcium channel blockers to allow control of heart rate and prolonged diastole, which will of course increase perfusion of the heart, and also we can give diuretics, which can be given for fluid overload. In terms of epidemiology of mitral stenosis, it's important to be aware that actually the incidence of cases is falling year on year, and this is due to a reduction in the cases of rheumatic heart disease, so there is a direct link between the 2. Mitral regurgitation is also really important to be aware of, so this is backflow of blood from the left ventricle to the left atrium, and actually this is present in 80% of the population, but can be of course asymptomatic in a lot of those patients. The most common cause is mitral valve prolapse, and essentially this is as a result of course, when the ventricles exert a lot of pressure during systole, normally the chordae tendineae keep that mitral valve closed and prevent prolapse. However, if you've got a condition that may weaken your connective tissue, such as Marfan's or Ehlers-Danlos syndrome, this can cause the valve to prolapse and of course leak blood back into the left atrium. NMI, or left-sided heart failure, can also cause damage to the papillary muscles or cause left ventricular dilatation, and as a result this can also cause either mitral valve prolapse or it can cause damage to the valve, so backflow of blood occurs. As we've said, most patients will be asymptomatic, but those that are symptomatic will have a soft sound 1 and a hollow systolic murmur. So what that means is you'll have a murmur for the entirety of systole at the apex, which will radiate to the axilla. It can cause left-sided heart failure due to increased preload as well, and volume overload will also contribute to the hypertrophy of the ventricles and as a result heart failure. It's important to be aware with all valvular abnormalities, the best way to diagnose them is a mix of a physical examination and auscultation, because each different murmur has a distinct murmur you will hear in different locations, but also echocardiogram, of course, is your main diagnostic tool. In terms of aortic stenosis, so we're now looking at the aortic valve, which is normally made up of 3 leaflets, a right, a left and a posterior, and this is located between the left ventricle and the aorta, so the outflow of the left ventricle to the rest of the body. Therefore, of course, it's going to open when the ventricles are contracting to allow blood to flow out, and close join diastole to allow the left ventricle to fill. Again, this shows the absolute difference in the aortic valve width of opening between a normal aortic valve and a stenotic aortic valve as well. So stenosis, again, remember, is narrowing of that valve opening. The causes of aortic stenosis include mechanical stress over time, so this is calcification in the elderly, and there's also a link to congenital causes in a large proportion of cases where people are born with a bicuspid aortic valve. In other words, it's got 2 cusps instead of the 3 that it should have, and this increases the risk of fibrosis. And of course, as we discussed earlier, you can also get fibrosis from rheumatic fever causing commissural fusion. It can cause left-sided heart failure if it pursues, because at the end of the day the left ventricle contracts during systole and blood should flow out to the aorta. In this case, a narrowing opening will require the ventricle to pump harder, generate higher pressures, and as a result the left ventricle will undergo hypertrophy to try and bulk up and overcome that resistance. In terms of diagnosis, we will see a crescendo, decrescendo classic murmur on auscultation, but of course, as always, echocardiogram and ECG are the best ways to allow you to visualize the valve and actually see what's going on. In terms of symptoms, they'll probably have shortness of breath, reduced exercise tolerance and chest pain, but also fainting or syncope is also associated. Aortic regurg, of course, dealing with the aortic valve again, but this is the backflow of blood from the aorta into the left ventricle. So regurgitation is, of course, remember, incompetence of that valve. The causes of this can be acute or chronic. So the acute causes include endocarditis and aortic dissection. So, for example, an aortic root dilatation. This widens the aortic root, leaving the left ventricle, and as a result pulls the leaflets apart. This is normally idiopathic, but can be linked to an aortic dissection or an aneurysm, so this is an example of an acute cause. In terms of chronic, it could be a bicuspid aortic valve, as we've just discussed, it can be rheumatic fever, and it can be infective endocarditis, so similar causes to the aortic stenosis. Occasionally, remember, you do tend to have a mix of the two, stenosis and regurgitation. In terms of diagnosis, again, you'll see that you'll see a murmur, but this time it's an early decrescendo murmur due to blood flow back into the left ventricle from the aorta. So there's a large gap as well between systolic and diastolic blood pressure. So this is called a high pulse pressure, which means you've got a hyperdynamic circulation, which will also cause you to feel a bounding pulse on examination. Taking a look at this image in the bottom corner, we can see actually that aortic regurgitation shows this classic decrescendo sign. In other words, the intensity of the sound decreases between sound 2 and sound 1 because it's a diastolic murmur. Next, we move on to the tricuspid valve. So this is a valve that sits between the right atrium and the right ventricle. And again, this is made up normally of 3 leaflets. So this time it's an anterior, a posterior, and a septal leaflet. Because it's an AV valve, you'll expect it to be closed during ventricular systole, so when the ventricles are contracting, in order to prevent the backflow of blood into the right atrium. And during ventricular diastole, so when the ventricles are relaxed and filling, you'll expect the tricuspid valve to be open, in order to allow blood to passively and actively flow from the right atrium to right ventricle. The most common cause of tricuspid stenosis, so remembering that stenosis is a narrowing of the tricuspid valve, is rheumatic fever, and this is by far the most common cause, and it leads to that chronic inflammation we've already discussed, fibrosis and commissural fusion as well. So the general rule here is that normally if you've got a problem with the tricuspid valve, the mitral and aortic valve are normally also affected as well, and either slightly stenosed or regurgitating, or a mix of the two. In terms of diagnosis, this time we'll hear a mid-diastolic murmur, so it sounds like a rumbling on auscultation. But obviously definitive diagnosis comes from an echocardiogram and ECG. In terms of clinical signs as well, you may see an increased JVP, particularly with a prominent A wave. You may also see peripheral edema and ascites in these patients. Tricuspid stenosis can also lead to right-sided heart failure, so key symptoms or signs here are distended neck veins, edema and hepatosplenomegaly. So of course this is an increase in the size of the liver and the spleen. In terms of treatment of tricuspid stenosis, we tend to lean towards surgery more, so a balloon valvuloplasty is the most common operation carried out, but also we can give medical treatments alongside the other valvular abnormalities such as diuretics, beta blockers or calcium channel blockers for their appropriate functions. Next we have tricuspid regurgitation, so again concerning the tricuspid valve, that valve between the right atrium and right ventricle, and in this case we've got regurgitation, so a backflow of blood from the right ventricle to the right atrium. The causes behind tricuspid regurgitation are a little bit different, so pulmonary hypertension, so this causes an increase in right ventricular pressure which dilates the tricuspid valve and causes that incompetence really for the blood to backflow into the right atrium. Rheumatic heart disease again is implicated, but this time it's fibrosis which causes them to not seal effectively. It's no commissural fusion in this case. They actually just don't seal effectively, and as a result blood can backflow through them. There's also papillary muscle damage to consider, which may be from an MI, and congenital causes as well, such as Epstein's anomaly, which is where you've got the leaflets lying too low. You will see again a holosystolic murmur on auscultation, so a murmur that lies through the whole of the systolic period because blood is flowing throughout the whole of systole. But again, echocardiogram and ECG are your definitive diagnosis here. Again, we've got some pathophysiology here, and what's really important about tricuspid regurgitation is it is a vicious cycle, because the right ventricle does try to compensate, but as a result this compensation actually means that even more blood leaks back into the right atrium during ventricular systole, so it's really trying to help itself, but as a result actually causing more damage. Lastly, we look at the pulmonary valve. So this is the valve which is located between the right ventricle and the pulmonary trunk, so the outflow of the right ventricle to the lungs, and it's made up again of three leaflets, so an anterior, a left and a right cusp. So during ventricular systole this will open to allow blood to flow out to the lungs, and during ventricular diastole it will close to allow ventricular filling from the right atrium. Pulmonary stenosis essentially again is the narrowing of the valve, so the narrowing of the pulmonary valve, and the causes behind this are congenital. For example, not having a fully developed or irregular shaped pulmonary valve. It's also associated with congenital abnormalities, which are covered in the next video, such as tetralogy of Fallot. And there are also mechanical stress over time in the elderly. With regards to diagnosis, it comes back to auscultation and an injection click just after heart sound 1, so this simply is a click that you'll hear, followed by a crescendo-decrescendo murmur, but again relying on echocardiograms for the definitive diagnosis. With regards to complications, it can cause right-sided heart failure, and therefore you should be linking the symptoms again to distended neck veins, edema and hepatosplenomegaly, but also it can cause microangiopathic hemolytic anemia. In other words, we damage the red blood cells as we're forcing them out of the heart through the pulmonary valve. This can form schistocytes, which leads to hemoglobinuria, so in other words, hemoglobin in the urine. Also be aware of cyanosis as being a sign or symptom in this case, because the blood's less able to reach the lungs, the right ventricle isn't as functional in pumping blood through the pulmonary valve, and therefore blood is less able to reach the lungs and not being perfused with oxygen as well as it should be, and cyanosis can develop. Lastly, we have pulmonary regurgitation, which is essentially a leaky pulmonary valve, so the backflow of blood into the right ventricle. The causes behind this include valvular damage, so this could be from something like infective endocarditis. It could be again linked to rheumatic heart disease, so the chronic inflammation, fibrosis, and where the valve doesn't seal properly, and also due to previous heart surgeries, so an incorrectly performed valvuloplasty or a malfunction in prosthetic valve can also cause pulmonary regurgitation. In terms of diagnosis, we think about a diastolic murmur this time, a decrescendo murmur on auscultation, and again echocardiogram for completeness. In terms of symptoms, it can be asymptomatic at first, but essentially the complications that can ensue include heart failure, so those triad of symptoms, again distended neck veins, edema and hepatosplenomegaly, but also we may see simply shortness of breath, chest pain, which is much worse on exertion for those suffering from pulmonary regurgitation. In terms of the mild form, there's actually a high epidemiology prevalence of pulmonary regurgitation, but as we've said, it can be asymptomatic at first. In terms of treatment, we'll aim to treat the underlying pathology, so we'll use diuretics, for example, to treat pulmonary hypertension. We'll also use anticoagulants to thin the blood and digoxin as well. In more advanced cases as well, we'll use surgical treatment, so valve replacements, in order to replace the pulmonary valve as a means of treatment. So that is everything for this video. I hope you found it useful. It really was a quick whistle-stop tour of valvular abnormalities, but obviously more information can be found about these in the pathophysiology section of the website. Thank you very much for listening, and I hope you found it useful.